Hello, and welcome to the Alabama Public Health Training Network. Patient-delivered partner therapy, a form of expedited partner therapy, is the clinical practice of treating the sexual partners of patients who tested positive for selected sexually transmitted diseases. Today, we will discuss the implementation of these therapies, also known as PDPT and EPT, at Alabama Department of Public Health County Health Departments. Thank you for joining us today for our program, STD Patient-Delivered Partner Therapy. Our objectives today are to explain expedited partner therapy and patient-delivered partner therapy, discuss legal issues of EPT, explain the purpose and protocol procedure for PDPT administration, list the appropriate PDPT candidates and exclusions, describe the counseling requirements for the index patient and the sex partner, describe the PDPT types and packages, and explain required documentation for the index patient and sex partners. If you have a question about anything being discussed today, please call or email our faculty presenter during our live broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluation are all available online. You'll need to register for this program in order to access those materials. Continuing education credit have been approved for nurses and social workers for today's program. The ADPT is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approval of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. The ADPT is also an approved provider of continuing social work education by the Alabama Board of Social Work Examiners. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While contents may continue to be relevant, CE credits will only be awarded for 1 year and will expire on October 31st, 2015. There's no financial relationship between the planners of this program and the speakers. There's no commercial support for this program. ADPH does not endorse any products that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. Please note, the contents of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by the ADPH should always check to clarify whether the contents is accurate according to the statutes, regulations, and policies of your respective jurisdiction or agency. I'm Lena Chapman, Alabama STD Surveillance Coordinator, and with me today is Agnes Obercourt, Nurse Practitioner Senior and with the Bureau of Communicable Diseases. Welcome.
Thank you, Lena Chapman. It's a great day today. I am very excited for what we're about to listen to today. This shows a great accomplishment for Alabama, ADPH, and a special Bureau of Communicable Diseases in the STD division. We started working on this project to be approved since 2011. And as you can see, from 2011 to today, it's been a long time. But it was a great team effort, and I'm very excited to present to you patient-delivered partner therapy. It's very exciting. Today, our program objectives include to explain expedited partner therapy, that's EPT, patient-delivered partner therapy, PDPT. We also discuss legal issues of EPT. We explain the purpose, protocol procedure for PDPT administration, list the appropriate PDPT candidates and exclusions, and also describe the counseling requirement for the index patient and the sex partner. There'll be packages involved for PDPT, and we'll try to describe the content of these packages, explain required documentation for the index patient as well as the sex partner. Now, EPT, Expedited Partner Therapy. Expedited Partner Therapy was introduced by CDC in 2005. Guidelines for the implementation was made available in 2006. Now, since then, several states adopted the guidance and implemented a form of EPT to help manage sex partners. So EPT is a sex partner management tool. In this process, the index patient must have a positive lab test for STD, and it's selective STDs, mostly chlamydia, gonorrhea, or trichomoniasis. Medication has to be prescribed or given, and it has to be oral therapy, mostly in a single dose form. Because of the nature of the process, multiple dosing is not convenient and it's not used. In this process, there'll be no medical evaluation, which means the partner will not come to the health department or the clinic or any provider for examination or evaluation. There's also no professional prevention counseling, since this patient or the partner will not see a health professional. So you ask, which are the states that are actually participating in EPT? When we started working to get Alabama involved in Expedited Partner Therapy, there were only about 25 states in 2011. As of today, we have 35 states participating actively in EPT. 9 states, as you can see, are potentially allowable, of which Alabama is one of them. And we have 6 states that EPT is actually prohibited in. Now, if a state has a permissible laws or rules to provide EPT services, providers in a state can give medicine to partners, to sex partners. In the states that are potentially allowable is when there are some rules and regulations that inhibit the practice of EPT freely to sex partners. Now, for the states that are prohibited, it's clear they cannot practice. Now, this being said, you will recall, or maybe you remember, or you have seen providers giving extra medicine to patients for your sex partners. I've seen it being practiced before. And even in this state where it's not potentially allowable and not freely permissible, I've seen it being practiced. Providers typically will give the patient extra medicine to be given to the sex partner. Now, although it's not fully legal, it doesn't mean they will lose their license. It's not just allowable in the state. For us to practice it as health department, we need it to be allowed, to be free, with no legal constraints. And we work hard on doing that. Let's look at some legal issues. If the procedure is to allow for a patient who will not be seen by a provider, there will be no professional counseling. That means there may be some issues that some people will have or concerns. And some of these are prescription labeling requirements. Well, this differs from state to state. For the state of Alabama, we must have name of the provider. We must have patient name, the medicine, the dosage. But the key thing about the prescription labeling requirement that we have to work on was the provision that the patient need to be seen by a provider in order to get prescription medicine. For general privacy laws, that prohibits EPT, mostly with the HIPAA regulations. Are we going to violate HIPAA laws when we practice EPT? We took all that into consideration. We are not disclosing the patient information, but we are providing medicine to be given to the partner. The patient information will still be under HIPAA rules and regulations. We will not disclose information, but we rely on the patient to disclose the state of the disease to the partner in order to get treatment. Monday, we do partner notification letter, where a patient takes a note to the partner to let them know there's a problem that they need to go to see a provider for. Now, the next legal issue concerning partner-patient relationship. Again, that is one of the reasons why we have to work it and make sure we get approval. In the state also, the rule is that a patient getting a prescription medicine must see a provider. Adverse medication reaction was another concern. What if a patient reacts to a medicine? What if they have some allergies? Are we going to be liable? And that leads into the professional liability. And that is the biggest concern, or the most questions that I always ask. Are we going to be liable if we give medicine to a patient we haven't seen and something happens? And with all this, we worked hard to make sure everyone is covered in ADPH. So are there other agencies that support EPT? Several. The American Medical Association, the American Congress of Obstetricians and Gynecologists, Planned Parenthood, the American Academy of Pediatrics. And I put American Bar Association in the middle because that is where almost all our legal questions and concerns goes to. They support EPT. They're actually working hard for states to understand, to remove some of the legal constraints around EPT so it can be implemented in some form. It's interesting, I was reading about Planned Parenthood, and I read where they actually give every patient that tested positive for chlamydia EPT services. They're given a medicine, they understand, and they give whatever number of patients, partners they have. So there are supporters out there who are using EPT or a form of EPT. There are more supporters. What about the National Coalition of STD Directors? You will say, well, they have to because they manage STDs. But I'm glad we have them listed as supporters. That gives us support and the confidence to introduce EPT. Well, another interesting group is the National Association of County and City Health Officials. If we can get their support, we know that we can implement and have some rules flexible on our behalf. EPT in Alabama. work with the Board of Nursing, the Board of Medical Examiners, Board of Pharmacy to get EPT approved in a form that we can utilize or administer in our counties. The Board of Nursing has to be involved in because most of our staff, clinical staff, are nurses. And we do give medicine to patients. So the Board of Nursing regulates what we do as nurses in the health department. The Board of Medical Examiners has to get involved because we're dealing with patient-provider relationship. We're dealing with prescription medicine. We're dealing with medical rules in the state and regulations. Board of Pharmacy, we have to get them involved because we are dispensing medicine. It's obvious. And we have to comply with the rules of the Board of Pharmacy. And we work to have patient-delivered partner therapy approved. Now, this is a legal provision for ADPH clinicians in county health departments only. You may wonder why it's in our statewide that everybody can use it. It will require more work. It will require more legislative changes. And since we are dealing with the whole state, we fought for what we could afford because of what we're going through. Why? We saw chlamydia going up every year. As a matter of fact, in 2009, and I have some numbers that I would like to show. You may not see, but in 2008, the number of chlamydia for the state was 24,700. 2009, we moved to 25,900. Come 2010, and we went 27,000. 2011, 29,000, and then 2012, 30,000. Now, as of today, by the end of August of 2014, we're already 25,000 we have reported. We have 4 months to go in a year, and we are almost there. So there's a need to do something about chlamydia. And that was the greatest force behind the reason for us fighting or working hard to get some form of EPT approved in the state of Alabama. Considering the concerns and regulations, there must be a protocol. We have to follow some guidelines in our clinics in order to have this administered. Therefore, for PDPT patient-delivered partner therapy in our clinics, we have 2 STDs that we want to consider: chlamydia and trichomoniasis. The index patient, though, must test positive for chlamydia or trichomoniasis. We must have a positive lab result. We are considering these 2 diseases because we can manage them by single-dose therapy. And it's oral therapy. As I said from the beginning, the preferred medication or recommendation is oral therapy. And it's good if it's single dose. And that is what we are trying to do. So we are going with chlamydia and trichomoniasis. You may say, what if we treat a patient presumptively? We cannot use PDPT for patients who are treated presumptively because we do not have a lab result. But what if the clinical presentation is so clear and obvious. Can we use it? No, we cannot. We will stay within our guidelines of using only for patients who tested positive for the disease. How do we do this? The procedure. Patient will normally come through our visit process, whether it's initial visit, where we test, we do everything we need to do, or maybe the deferred physical exam process. But PDPT will start during the revisit, when the patient actually comes back for treatment because we have a positive lab result. So we will follow the routine revisit procedure for treatment. We also need to determine if the patient is appropriate for the services we're about to provide for PDPT. Again, I'll keep going back to the concerns we have and how we have to work through it, and the reason why we need to follow the protocol rigidly. It's not convenient, or it's not allowed for all patients. It's selective, and even with the selective patients, we still have to make sure they are appropriate for the services we're about to provide. We need to determine if the patient can personally deliver the regular partner notification letter. Because what do? When the patient tests positive, we give them partner notification letter to inform the partners to come back to the health department or go to a health provider for treatment. So we will deliver and make sure we give partner notification letter and ask the patient if they can deliver the note to the partner, the sex partner. When we determine that they can, we provide PDPT counseling. We'll provide the appropriate package, which I'll go through, and then also document appropriately. Now, who are the appropriate candidates? Sex partner of an index patient with positive chlamydia or trichomoniasis test result. We can also provide PDPT to trichomoniasis when the trichomoniasis is found in a wet mount. It got to be active trichomonad. We diagnose by wet mount. Also, we need to determine the ability of the index patient personally delivering the partner notification letter to the sex partner. Now, the reason why we are stressing this point is that if a patient cannot take a letter to the sex partner, how can we give medicine to such a patient? So we must make sure first that they are capable or have the ability to deliver the letter to the sex partner. Well, I've seen many cases where a patient will say, I am not going to see them anymore. I am through with them. They are mad. They have infection. They've been given something they're not looking out for. So we have to be sure that this patient can. I had an interesting case on Friday when I was training, and I thought I was perfect. She tested positive for chlamydia, and she came for treatment. When I was giving her the letter, she said, yes, I can deliver this patient, this letter to my partner. Then she asked me, is there any way I could take a medicine for him? And I said, if you come back on October 15, I could. She looked at me and said, what do you mean? What's happening on October 15? And I said, October 15, we'll be able to give you the medicine. But for now, you have to take a letter to him and let him come back. And he said, I will. And can we come back on Monday? I said, yes. Now, this is a good candidate. She was willing to take the letter to the partner, and she acts. She was serious. I could see the urgency in her voice and the way she was talking to me. And I thought, this is a good candidate. If we can have all of them like this, it would be good. But it will be challenging for some of the patients. And we need to really clarify and make sure that we are not giving medicine to somebody who just threw it away or just keep it in his or her house. So we have exclusions. Sex matter of a patient diagnosed with syphilis, gonorrhea, or co-infection with HIV. Why can't we do this? With syphilis, there's more to be done for such a patient. We have to do contact tracing. There may be some complications. We need to see those patients. Gonorrhea, co-infection with HIV. Well, you can see gonorrhea, we need IM therapy. So is syphilis. And with HIV co-infection, we want to see patients. We will not do PDPT for those patients. Now, other patients that we cannot provide PDPT services to will be pregnant women. Too much risk involved. And a male patient whose female sex partner is pregnant or may be pregnant. We have to ask the patient. And the only way to know is to ask and make sure we double check with these patients. Patients less than 12 years of age are excluded as well. They are minors. We know such patients, there may be possibility of abuse, and we need to find out so we will not deliver medicine to those patients. Patients who indicate that they cannot personally deliver partner notification letter to the partners are disqualified, as I said several times. To me, that's key to this process. So a patient may not be pregnant, may be the right candidate, but if they cannot take the letter to the partner, they are excluded from the process. Once we determine that a patient is appropriate for PDPT, we need to obtain the needed information. We need a partner name, date of birth or age, and medication allergy status. Now, most states only require to have the name and date of birth. But we want to go a step further to check on allergy. We need to have the allergy status before we dispense. The questions I have back when we're reviewing this was that what if they don't have the full name of the partner? We accept if they give the first name, the home name, the street name, we use that because that is what they are known for. So if they give us only one name or whatever nickname we have, we will use that in our documentation. What if they don't know their date of birth or age? It's possible. We'll write unknown. At least we are tempted to find out. So we write unknown. Or they can give us estimate, and we can use that. Again, what if they don't know their allergy status? Should that stop us from doing it? No. We'll write unknown. We ask. And you will know the reason why. Because the package that will be sending with the patient will include more informed items in there that can help the patient determine whether they need to take the medicine or not. Patient counseling. This is very critical because the partner who will be taking the medicine is not in the clinic. We are not talking to this patient. So the counseling we will have given to the patient who will be taking the medicine will be given to the index patient, the one that tested positive. So this is very important. And we have to make sure that we go step by step and explain all the procedures and what needed to be done for the partner. Again, the first item on counseling is personal delivery of the packet to the partner. Now, the patient agreed to take the partner notification letter to the partner, and that is why we started the process. But now we want to make sure they will deliver the packet, so we need to discuss that. I have sample of the packet for the patient. In the packet, you can see we are delivering for trichomoniasis or chlamydia. So we have two packets. We cannot mix them. In the packet, we have the medicine. We need to be labeled. We have a label. We need to put a name provided on the label. We also have the material that needs to go with the packet. The disease information is on the form. So for trichomoniasis, we explain here what trichomoniasis means. So it means you're actually reading over to the patient for them to understand, because they need to hear it too. That's what he had. And then we go over the medication. We said do not take the medicine and see a provider, your doctor, or come to the health department if you're a female and having lower abdominal pain. Pain during sex, abnormal vaginal bleeding, vomiting, fever, or pregnant. And you can see we're repeating the counseling process here, what we talked about. We want to repeat and make sure the patient understands what we're trying to send with her or him to the partner. We want to know if they are male partners, it's okay. If they have pain in the testicles, we don't know that. So we have to send this information containing all this information. And they have to read. So we need to go step by step with the index patient in explaining the process to them. And that is how they will also go home and explain to the sex partner. On the form, you get to a point where it asks for clinic, where the patient should call the health department. That's where you put the clinic phone number, where the patient is given the package from. We need to remind them again that they need to abstain from sex while they're taking the medicine. They have a spot where you have your clinic number, again repeating where to call if they have any problem with the medicine, any allergy, any adverse reaction to the medicine, where they need to call. Also in the packet, we will have our routine PIL, the patient information leaflet, listing everything about the medication in a packet, what to expect, what to look for, what to report to the health provider. So with all this, we are making sure that we send the necessary counseling information through the index patient to the partner. That is why I said earlier that if they do not know the allergy status of their sex partner, we can still give because we have it in the package for them to read, go over, understand that if they have any allergy, then they're not supposed to take the medicine. So we went over the medication information, precautions to avoid spreading or come back with reinfection, and that is avoiding sexual relation until they both get treatment. One of the importance of medical evaluation, we have to stress to them, the fact that we are giving the medicine to them doesn't mean they shouldn't see a provider or come back to us. We are ready to see them, but it's a process to hasten treatment to make sure they were treated and not getting reinfected. I remember not too long ago, one of our field operation managers were working on a patient who tested positive for trichomoniasis. The patient was treated, and a month later, she came back again with symptoms, tested positive again. She said, I took my medicine, I was fine, but I came back again. And then he asked, did your partner get treatment? I said, yes. I told him, and he said he went to the health department and got treatment. So the staff called the partner this time and asked, where did you go for your treatment? He said, oh, I never got a time to go for treatment. So these happen. It happens all the time. There's a need for us to stress spreading infection and preventing reinfection. I've had several calls from counties about similar cases. Actually, I can get a call say, Agnes, should we keep testing these people who will never bring their sex partners? And my answer is that if we test and they come back positive, we have to treat. How many times we test, we have to keep treating them. And that was one of the reasons why I thought PDPT services in our clinics will be very effective or useful for our patients. Again, it's not for everyone, but at least for those that we can identify, it will be useful to them. We have to be very careful who we give it to, and that is why we need to make sure we do counseling, ask questions, and make sure that we are giving the package to the right person, the right patient to be given to the partners. We need to go over the package with the index patient to make sure they understand what to tell the sex partner. If we are not able to accomplish that, the process will be defeated. We cannot have a good process at the end of the day. As I said earlier, the medicine must be pre-packed, labeled with the sex partner's information. We must have the chlamydia, treatment for chlamydia, separate, azithromycin 1 gram in a single dose. If it's trich, we have the medicine metronidazole 2 grams in a single dose. And it must accompanied by the medication PIL, patient information leaflet for chlamydia or trichomoniasis. PIL comes in the English and Spanish version. Now, all the other information that is needed, that the material that will be included, will also be translated into a Spanish version, so all our Spanish population can also benefit from PDPT. In the packet, we also need to include a partner notification letter. This will encourage the patient to call and come for medical evaluation. How many partners can we treat? Some of the questions that came earlier. We want to treat up to 5 known partners in the past 60 days, or the most recent partners. Can we do this forever for one patient? For now, we said 2 services per year. That means that patients come to this clinic today and we provided PDPT services. They can come back again within a year and we provide again. What if they come back 3-4 times within a year? We will not do it after the second one within a year for now, until we have evaluated the process and make sure that it's not being abused. We don't want the process to be abused. What I hear most from the clinic is that when they start doing something, the word go out. So the word will go out and they say now, oh, we can get medicine for our partners without them showing up. Well, we want them to know that, but we don't want them to abuse the process and just come and take medicine. So we were doing a 5 partners within the past 60 days, or the most recent partner. I just went over the written material that need to go into the packet. And I want to stress it again, that we need to go over with the index patient, because they will do our counseling for us when they get home. So we want them to understand everything in the packet, in the material we provided. We don't want them to understand and have information about the STD or the disease that's being treated. We want them to know about the medicine that we've given them, especially for metronidazole. If they're using any alcoholic beverages, they need to know that they cannot use it while taking the medicine. They need to wait 24 hours after taking the medicine before they can take any alcoholic beverages. Another thing that the literature talks about alcohol is if they have serious alcohol problems. How do we know? We wouldn't know, but we have to let them understand that if they have any serious alcohol problem, they need to stop taking. They shouldn't start at all. They need to see a provider or come to the health department. We also need to make them understand precautions, avoiding sexual relations. We will not tell them to use condoms. Otherwise, we are blessing them to have sex, and you know they won't. Or they will tell you their condom broke. So it's precaution, again, avoiding, and then prevention strategies to make sure they are treated before resuming any sexual activities. Why do we need clinic contact information on the form? We need it so the patient can call for questions. Questions about the medicine. Questions about any problems that a partner may have. Then the sex partner can also call to make an appointment for evaluation, or call for questions about the medicine we provided or any instructions in the packet. They can also call to report any adverse reaction to the medicine we just given them. We just want to cover everything that may be a concern to the patient or to the health department. And so we need the clinic information to be on the information that we are being provided. We just finished counseling. Now, all this counseling needs to be documented. The medication we're giving needs to be documented. So now we're on documentation. Documentations we're having on CHR. It will include the pregnancy status of a female sex partner, type and number of PDPT packages where we're giving to the sex partner, and the prevention counseling we just provided. We updated some of the forms that we use in the clinic. And I'll put on the screen. You will not see everything, but if you're familiar with the form, we've updated and to the point that we included pregnancy status of a male partner, a sex partner, a female sex partner of male patient. So this is not on the old form, but it's new one that have been updated. Once you check a male patient, you have the female sex partner, you have to check the pregnancy status. Now, if you're not using the CHR-12C, you're using a progress note, remember to have this documented as well. At the therapy session, we updated to include the PDPT packages involved. We have the chlamydia and trichomoniasis on the form. I know the form is small. You can't read the whole thing on the screen, on the slide, but if you use this form, you know exactly where it is, where it needs to be. Check it and write the number provided. You check PDPT for chlamydia, and then the packet up to 5. And so for trichomoniasis as well. Now the question is that, what if a patient tested positive for chlamydia and trichomoniasis at the same time? That means we are providing 2 packages, one for chlamydia and one for trichomoniasis. We will provide both packages at the same time for the patient. We will go over the instructions separately. Go over chlamydia and then go over trichomoniasis. Don't just go over one and just give the other one to the patient without explanation. Prevention counseling. Also, at the counseling section on the form, we have included PDPT session to be checked. So you check it, making sure that it's done. And it's a reminder when you are counseling that you remember and counsel and document that you have gone through the process counseling with the patient. More documentation. Information. The sex partner name must not be written in the index patient's chart. If we do that, if we put sex partner information or name in the index patient chart, it will violate HIPAA regulations. Another thing is that the sex partner do not require a medical chart or CHR in order to receive PDPT services. However, there will be some form of documentation to show that we have such a patient, we have the number of patients, the partners that the patient gave us, and we have documentations for the medication we provided. On the medication log, we need to make it clear what we are doing in reference to PDPT. I have samples of what goes on in the clinic. But first, let's say we have a patient comes in, positive for chlamydia. The patient said, I have 3 sex partners. The patient is an appropriate candidate for PDPT because they're not pregnant, they are more than 12 years of age, they don't have dual infection with HIV or gonorrhea, they don't have syphilis. So we get 3 partners. They qualify, they are within the past 60 days. The partners also are not pregnant. They don't have HIV or syphilis that the patient knows about. So we decided we will provide PDPT services. We will have the medication here. So this will be the PDPT dispensing, medication dispensing log, which will be provided for the counties. We have our medicine listed as azithromycin, 500 milligrams. We are given 1 gram. So we have our name, the date. We can put the index patient's FICON label here at this column, or we will write the name. So for the disease being treated, we have CT. We have the number of sex partners that the patient gave us. We need their names on this column. So number 1 name, number 2, number 3. We list it all on each separate lines. We have their age or date of birth, and if the medication allergy status that we ask. We document everything here. Now this is for the PDPT log. Now the next one is an actual medication log in the clinic. Again, we have the patient's index, patient's FICON label or name, or CHR number. We administered their medication. Remember, they're in for treatment as well. So we treat them and we administer the medication. So we started with 30 supply in the bottle. We took the 1 gram out, that's 2 of those 5 milligrams. We have a balance of 28. Now let's come to the index patient sex partners. She said 3 on our previous form. The log, she gave us 3. So now we are dispensing for the 3. So we started again here. We dispensed this time. The first we administered, and now we're dispensing. Now let me emphasize here that we need to follow the medication, the CP and the protocol manual on medication administration in pharmacy. We have to comply with that rule. So we will follow the medication log and flow sheet as outlined in the CPM for medication administration in pharmacy. Excuse me. So we administered in a clinic for the index patient. Now we are dispensing. Excuse me. And that will be in each package. Every index patient or partner, every sex partner will get a package. Remember, all the three will not be in the same package. 3 bottles of medicine will not be in one package. You have to have 3 packages for chlamydia, PDPT. So we dispense 6. That means 2 for each partner. We have PDPT under it. So everybody who picks up this log or flow sheet will understand what we did. They will understand that the index patient had chlamydia and the index patient had 3 sex partners. And we gave the medicine. And it will correspond correctly with the PDPT log as well. I hope this is clear. We will take a break and come back with more information about PDPT. Thank you.
Hello, and welcome back to STD Patient-Delivered Partner Therapy. Nurse Alvacard will go over some of the documentation, especially the forms, to make sure that you fully understand what is being said.
Thank you, Lena. I think I'll go back and start with the documentation on the CHR 12C. Again, you may not be using the CHR 12C. You may be using the CHR 12A, as in family planning, or you may just use a progress note since this will be a follow-up visit and not initial visit. So what I indicated from the beginning was that on the form you document as usual when the patient is coming in for revisit. The patient is coming back, you have a positive test result, the patient has been called by DIS to come in, and the patient is in the clinic. In addition to everything you would do for this patient in revisit, during the revisit process, you will include information about the female sex partner pregnancy status. And for the CHR 12C, we have included that question in the partner history. You need to write it in your form or any other form you're using or documentation process you're using. If it's progress note, CHR 12C, 12As, you need to write it down. We just want to be sure that this patient has a partner who is not pregnant or pregnant. We need to know the status. Another information is the packet, the PDPT packaging we provided. It's not a patient's name. It's just on a therapy section where we have all the medications listed. We want to list what package we provided. Is it CT, how many we provided. If it's TV, how many packages we provided. Again, we are providing up to 5 for one index patient. And then for the prevention, we have additional where we just need to check to make sure that we have it covered. If it's chlamydia, you check PDPT and then check chlamydia or TV if that's what you are treating for. Now I'll go over the medication log, the medication documentation. Like I said, it will be part of what we'll be doing, and we need to take it very seriously here. And so I'll go over. Once we have our package ready for the patient, and we know the number of sex partners we're about to give the packet to, we use the PDPT log, this medication dispensing log, and it's in the protocol that will be coming out. What we'll do here is have the date. First of all, the medication we're about to give is for chlamydia. Therefore, we have azithromycin. 500 milligrams, we're giving 2 of them. That's 1 gram. We have the name of the date. We're giving the services. Then the index patient's name. You can use the FACON label here or the patient's name if you choose to write it in. Again, we have CT. And if the patient said I have 3 partners, in which case this patient said they have 3, as an example, we have their names here. We have to list the names given. If it's just the name is the Bobo, we just put Bobo in here. If they know full name, that's great. But whatever name we're given, we will have that listed on the form, each on separate lines. It names each line for a name. Date of birth, or the age, and then medication allergy on the last column here. If they don't know the exact date of birth or age, we will encourage them to give us approximate or whatever they know so we can have it in our documentation. Now when we have this, after we get this done, now we have to go on the current medication flow sheet. Remember, I said we need to comply with the medication administration instructions in the CPM. That's a clinic protocol manual. So this is the current medication flow sheet that we are using in the clinics, ADPH clinics right now. We have a medication name on it, azithromycin. For 340B pricing purposes, we circle is for STD because that's what we are treating. We have the NDC numbers, the line numbers, strength, and expiration dates as usual. We need to have them. Now we have the patient name, FACON label, or CHR number. We have to administer for the patient because this is the actual patient we are treating in the clinic. We have the date. Maybe we start with a new bottle of azithromycin. That's why we have 30 on hand. And we give the patient 2. We're left at 28 in a bottle. We sign. We put the same patient, FACON label or CHR number. And this time we are going to dispense for the sex partner. Now, based on what we have initially for the PDPT log, we said that she gave us 3 sex partners. So we are going to dispense for 3. And so if we had 28 from the beginning and we took 6, remember we 2 per patient, that's 1 gram. Now our balance is 22. And we'll have to indicate here PDPT so anybody who comes behind us will understand what we just did. That we had a patient who tested positive for chlamydia, and we treated them. The patient had 3 sex partners, all appropriate for PDPT, so we delivered medicine to be sent to the sex partners. I hope this clarifies the documentation and the logbook a little better for all of us. I've already mentioned the need to comply with the current STD medication dispensing protocol in the CPM for medication administration and pharmacy. Very important, because the provisions was made and agreed by the Board of Pharmacy, and we have to follow all the requirement that we have. The protocol has been reviewed. The protocol is good for this practice if we follow and comply with the regulations or the rules that we already have. We do not want to get in trouble, so we need to follow it. Again, I already mentioned documentation on the standardized medication logbook for PDPT. We have the index patient name, or we use the FACON label. We indicate the type of STD to be treated. We went to the sex partner column. We have the name, a number of sex partners that we need to treat. And remember, we said up to 5 non-sex partners in the past 60 days, or the most recent. We take their name, date of birth, and age, and medication allergies. Now let's go to another area of importance in this process: adverse reaction reporting. The patient, I think we have a call in, and we will take the call.
Yeah, we have a call from Tuscaloosa County.
Hello, Tuscaloosa County.
Yes. My question, I just needed some further clarification about the exclusion patients.
Yes.
Now, if they have gonorrhea, as well as chlamydia and trichomonas, or either or. Now, if they have gonorrhea, period, would that mean their partner is automatically excluded?
Yes.
Or so you don't treat them for the other infections, you just tell them to tell the partner to come in?
Yes, we just tell the partners to come in. We give them the partner notification letter. And I'm glad you asked that question. I'll go over the partner notification letter so we know exactly how to let them know what to tell the partners.
Okay.
I have this in here for chlamydia or trichomonas, but it's okay. It's the same thing. Now, sorry, let me turn around. In case of gonorrhea, we will treat the patient because they came in for positive test, positive gonorrhea. This will be gonorrhea. We list it. Then we have a check, and we say inform your sex partner to come to the health department or go to their private provider. We also let them understand to avoid sexual intercourse until the partner call or the partner is treated. And their sex partner will infect them if they continue to have sex with them untreated. Now, when we come out here, there's a column here that we have, and I hope you use the same thing in your clinic. We need to give this form to them with our county, that will be Tuscaloosa County. We check the days that we want them to come in, and the time, and the number to call. We put a code here, and for the code, every clinic has their own typical code, because most of them do not want the patients to know what they're coming. They only understand when they bring the form. But other clinics, they actually put the disease name so the patient would know. And this goes with the patient and let them give it to the sex partners to come in. So this is what we would do for chlamydia, for gonorrhea. Or if the patient is co-infected with gonorrhea, chlamydia and gonorrhea, or trichomonas and gonorrhea, we need to let them come in, because we cannot treat the partner, sex partner, for trichomonas or chlamydia and leave the gonorrhea untreated.
Okay.
So that is why we need to let them come in if they have gonorrhea.
Okay, thank
or co-infected. You're welcome.
We have another caller.
Yeah, we have another caller from Mobile County.
Hello.
Hey, Agnes, it's Debbie in Mobile County.
Hi, Debbie. How are you?
I'm good. We have a question with the, we noticed that the labels on the medicine bottles in the packets was computer generated.
Yes.
Will handwritten labels be acceptable? We don't have the capability in the nursing area to do that.
Oh, absolutely. Handwritten is acceptable.
That's what I needed to know.
We just need to make sure we have all the information on the label.
As much as they have.
Yes.
All right, Miss Agnes, thank you so much.
You're welcome. Don't forget, we need to also include the name of the medication, the dosage, and the direction to how to take it on the bottle as well. Okay, great questions.
Questions? Any questions at this time?
I've got one question listed here, and that question is with regards to determining if the patient can deliver the therapy. And I think basically what you're saying is that's probably going to be a judgment call on the particular nurse or practitioner that's actually seeing the patient. Is that my understanding?
That's correct. And I think, again, coming back to our partner notification letter, we have on our partner notification letter that goes to the partner through the patient, we have a line here that say give or send to your sex partner. Well, in this case, we have to make sure that they can actually give this notification letter to the sex partner. And so that becomes a judgment call, because depending on how you ask the question and the patient respond to it, it will be a little bit subjective, because sometimes I will maybe handle it a different way. In the way I ask the question, can you deliver that? Can you actually give this notification letter to your partner? But you may ask in a different way, and you may get a different answer from the patient. So I can say yes, it's a judgment call, and we have to be really creative on this. We know our patients. We know when we are asking questions how they respond to it, and so that will determine how we handle that from there. So it will be how we generate questions from them and how they respond to us will determine whether they can take the medicine to them or not. But we need to be sure that we actually have an agreement with the patient that they will actually take the medicine to the patient, to their partner.
Are there any other questions?
Okay. I have a question for you.
Yes.
All right. If a patient comes in and names you 3 partners today, leaves the clinic, 3 days later comes back and says, I just remember 2 more patients. Can you go ahead and give them medication?
That's a good question. And I hope everybody understands the question. Assuming we give PDPT services today to a patient who listed, maybe gave us 2 or 3 partners, and then 2 or 3 days later they come back to the clinic and they say, I forgot 2 more patients that are partners that I forgot to give to you. Can I get the medicine for them? It's acceptable if they come within 3 days. We will honor what they're telling us. Within 3 days we will give, as long as we are within 5. We will not go more than 5. If this patient come back after 30 days, we have to retest. We have to do tests to make sure that they actually treated or they still have the disease. Again, we do not want this to be something that patient would just come in and abuse the process.
Okay. I have a question. In developing this protocol, how long did it take you and what processes did you have to go through in getting it approved?
Oh, this is great. We started working on this process, getting EPT, a form of EPT approved in March 2011. That's when we started. And we had several meetings within leaders in the ADPH, talking about, we met with Dr. Williamson, Dr. Miller, Bureau of Communicable Disease leaders, STD director, the staff, Family Health Services, the legal division, and nursing division. All these leaders were involved. We met many, many times that I cannot count. Then we proceeded. Once we get things clear up and agree that this is what we want to do, with approval from Dr. Williamson, we proceeded to contact the Board of Nursing, the Board of Medical Examiners, and Board of Pharmacy. We met also many times to make sure we understand all the processes. I believe the most challenging point in the process was with the Board of Pharmacy, where we have to make sure that we really comply with the state regulations on labeling requirement, and the fact that the law states that there must be a patient-provider relationship. And that took us some time to get it clarified. But with the help of Board of Pharmacy and all the other boards, we're able to come out with some rule modification, administrative rule modifications, so we can provide the services. As I said from the beginning, for the state of Alabama, EPT is actually potentially allowed because in the laws of the state, ADPH is allowed, nurses are allowed to give medicine to patients. That help with the process. And in addition to that, some providers were doing it. Although it's not fully permissible, it is not illegal for them to do. And that is, they will not lose their license, but it's just not professionally acceptable in the process. So we're able to go through this process, and this year, 2014, April or May, it was approved through the leaders. I think we went through, it wasn't a legislative changes, but it still went through the administrative leaders. We have to actually have it on record for the state, and people will look, it was there for about 30 days for comment from the state, everybody, consumers and providers. I remember when the recorders came to record a session, and I was asked to say something. Actually, I didn't know what to say, but I remembered all that we did. And so was able to provide a statement to be sent out for approval. And we did. So that is how we came through. I can't tell you how many times we met and called and did everything. But the leaders, the team that worked with us, very, very diligent. And I really thank all our leaders that work with the process to have it done.
Okay. Do we have another question?
Yes, we do have another question. That question is, are there any plans being made for this type of treatment to be used to treat any other STDs?
There are no other plans, and I don't foresee any in the future, because if we are giving the medicine to the patient, the index patient, to be given to the sex partner, we have to make it, we have to be reasonable, and we have to make it doable. A partner, if we give an injectable to the patient to be given to the partner, they will need some form of professional services. And that would not be expedited partner therapy, because then they need to call wherever, get an appointment to get injection. I would say though that for gonorrhea, when we're using the oral therapy like Cefixime, or when we had ofloxacin back in the days, when it was used, some states used that. And now that we are not using any oral therapy for gonorrhea, I don't think there's any state that's actually using EPT for gonorrhea. But I'll say that for gonorrhea, maybe there's the chances or maybe a plan to use it whenever we get a good oral therapy. That'll be a single dose in the future. For syphilis, I do not think so. I don't think there's anything in the pipeline, oral therapy for syphilis, that will be approved. Although now we do doxycycline, tetracycline, you know, even for early syphilis, we do 2 weeks. And for late syphilis, a whole month, 28 days. So that would not be given. So for gonorrhea, I would say yes for gonorrhea, but for other STDs, syphilis that we treat, it may be PID, no, because there's too many complications that is already there for PID. For epididymitis, no, it's a complication. Chancroid, there's no single therapy for chancroid as of this time. And those are just the common STDs that we encounter most often in the clinics that we cannot use for it. Thank you.
Are there any other questions?
Yes, there is. We noticed that before on your logbook, you actually had places there to for the index patient to list the names of their partners. Well, because quite often in STD, some of our people just don't know their partners' names because JoJo, Billy, and Blue are not real names. In this particular case, where they only know nicknames, will those patients be allowed to take those therapies to those partners?
Yes, they will be allowed. If those sex partners or the patient meet the criteria for PDPT and it's a candidate, we will give. All we have to do is make sure we put a nickname on the form. Because if we're looking for that sex partner, that's the only name we use, the nickname. Thank you.
Will that sex partner have to come into the health department to be tested, examined? The one that's receiving the therapy?
Oh, yes. We encourage that. We encourage sex partners to come back to the health department. And in the form, if you can recall, we said we need to have our clinic contact information so they can call the health department. So it's part of the package. It's actually an important factor of the PDPT being approved for the health department to use. We have to make a provision that the sex partner can come to the health department or go to a provider for care. And actually, again, let me just clarify it again, very important question, because in our information that we send out with the patient, the first question is that if they have any problem, they cannot take the medicine, they do not need to take the medicine, they need to see their doctor immediately. So that is very important. They need to do that. It's part of our question, our information, the package. So yes, we do encourage sex partners to get evaluation, get examined, and it's part of our material that goes out for the partner.
Okay. Are there any other comments or questions? Agnes?
Okay, without further question, let me go back one more time, make sure we got covered. Yes, we did. So now let's talk about adverse reaction reporting. So we give this package to the patient to be given to the sex partner. We've given all the information. What if there's a problem? Now let me say that as of today, that I did my last review, CDC indicates that there has not been any adverse reaction or reporting related to EPT. So since it's been implemented in the state, no report as of this day. However, we need to provide phone number and a means for the patient or the partner to report. And so they need to report to the health department, the county health department where they receive the services. And anytime the clinic receives any report on adverse reaction, the clinic needs to report it to the STD division. And the number is provided, 334-206-5350. So that is how we need to report to the STD division any adverse reaction. And I think we have another phone call.
We do from Arkansas.
Okay, great.
Hi.
Hello.
I am a nurse practitioner with the Department of Health.
Yes.
And I see a lot of people, and with our protocols, we have a treatment for MPC, mucopurulent cervicitis, which is a treatment for azithromycin. Do you only send partner treatment home with a positive chlamydia?
Yes.
Okay.
We are only treating positive tests.
Is there a test available that you could do in the office that would give you a positive that day?
No, we don't.
Urine?
No, we do not have any test, a stock test for chlamydia at this time.
Okay.
So we'll wait for the test results to come back.
Okay. Okay. All righty. Thank you very much. This is very interesting. Thank you very much.
You're very welcome.
Another phone call.
I think we have another phone call.
Yeah, we have another one from Montgomery County.
Yes. Montgomery County.
Thank you. Yes, this is Fred Coley of the Montgomery County Health Department. How you doing, Agnes?
Doing good, Fred. How are you?
I'm doing fine, ma'am. I was calling to touch base with you and see in the instructions that we've been getting, specifically whose responsibility is going to be to do the documentation for the medicine and the things that you've enumerated?
The nurses.
The nurses?
The nurses are going to provide the medicine. And this will be done during the revisit of the patient. Typically, revisit is when the patient is coming back to the clinic for services that we provided earlier. And for these purposes, it will be for treatment. So a patient is coming back to the clinic because you, Fred, called this patient to come to the clinic because they have positive chlamydia. And so you give your field record to the nurse. And so the nurse will take it, and if the patient is an appropriate candidate for PDPT, they will initiate, and the nurse will make sure the medication log is completed.
Okay. All right. Thank you. I appreciate that.
You're welcome.
Okay.
I think we have another call.
We do. This one's from Calhoun County.
Great. Hello, Calhoun County.
Yes. What do we do when we give the medicine to the patient and then say she comes back 3 days later and loses the medicine for her partners? What do we do?
3 days later, she comes back and the medicine is gone. Okay. I would say within 3 days, let's reissue another set of medicine.
Okay, thank you.
You're welcome. Good question.
Are there any other questions from the floor?
Okay. We are moving on. So the next step, implementation. We have updated the clinic protocol to include the implementation of PDPT. That is coming out on October 15th. So October 15th, where the clinic protocols are being revised and released, you will see PDPT protocol in this revision. Just follow the protocol and provide those services. If you have any question about the implementation, call me Now, what I need to add to this is that some clinics do dispense medicine to patients. Now, this process will not be difficult for them because they already know how to do it. They already have the medication containers or bottles to do that. If you're in a clinic that you've never dispensed medicine to a patient, then you may need to get some necessary supply, like the medication bottle where you put your medicine in. Maybe the label for the bottle. You may need a hasty label just to put on it so you can write on, because the bottle needs to be labeled. Again, if you have any question as to how to implement this protocol that is coming out effective October 15, let me know as soon as possible. How are we going to monitor this process? Our documentation will help us. And that is why we are trying to make sure that the log, the medication log, the flow sheet, and the PDPT medication log is actually done well. And that will help us to monitor this process. Make sure you use the flow sheet, the medication, the current medication flow sheet. And I have it on the screen again for you to see the importance of making sure that you administer the patient medication in the clinic. So the administration, the patient must be treated, indicating you get the patient medicine. And then dispense for the sex partners. Now, let's say you treated a patient on the day of the visit, and the lab comes back positive, and the patient is called, the patient showed up in the clinic. Can you provide PDPT? Yes. The patient must be present in the clinic. And so you can dispense the medicine for the sex partners. If the patient said, oops, I already had sex with my partner, the patient needs to be treated again. Administer the treatment to the patient again and dispense for the sex partners. Because if you don't, they will pass on the infection back and forth again. Evaluation. We intend to evaluate this process in a year. Although CDC and other states that are currently administering PDPT or a form of EPT said it's hard to evaluate because, number one, we may not have the right name of these patients. We may not know whether the medicine was actually delivered or given to the sex partner. So evaluation is not something that is already in the system or a state has it perfect that we can use. But we do our best to come out with an evaluation. Hopefully, we pave the path for other states to look at on how to do the evaluation or evaluate this process. In summary, we said PDPT is a form of EPT. It's a sex partner management strategy to improve partner treatment and reduce reinfection. Though the patient or the index patient must be an appropriate patient, must qualify. And so we have appropriate, candidate, and exclusions. We have a phone call.
Yeah, this call is from Colbert County.
Hello, Colbert.
Hi. Hi, Agnes. This is Rhonda from Colbert County.
Hi, Rhonda.
Listen, what if we have, oftentimes we have patients that come in the door from,
Are you on, Rhonda?
Yes, I'm sorry.
Okay.
We have clients that come in who are private patients from private doctors with positive chlamydia tests. Can we treat those people, and can we do the partner therapy for those people?
If you have a positive test, yes, you can. You follow all the procedure for treating a patient coming in for treatment. Then you can offer. But we must have a positive test on hand to show that the patient has a positive test.
Awesome. Okay, thanks. This is great. Thank you.
Thank you. No more questions? Okay. And I said earlier, PDPT has been approved for only ADPH county clinics. That means if you work somewhere else, you cannot use it. Maybe you work for the health department, but you work for another clinic, private clinic, or somewhere else. You cannot use it there because you will not be covered in those clinics if something go wrong. We limit index patient to the ones with positive chlamydia or trichomoniasis. Any question from the floor?
Yes, I have a question. This question is coming in from Lee County Health Department. The question is, if the patient is returning, if the index patient is returning to the clinic for a revisit, just for treatment, we usually just use the stamp for treatment. Will we now have to complete the CHR-12 again when the patient comes back in order to do the PDPT?
No, you don't have to complete the CHR-12C. With a stamp, you will write, make sure you write, if the patient is a male patient, ask them about their sexual partners. If they have a female sexual partner who is pregnant or may be pregnant, you cannot give them PDPT services. So you need to write that in. It will not be on your ink, but you just have to write that in. Again, then you have to write what type of PDPT service you're given. Is it for chlamydia? Is it for trichomoniasis? Or is it both? Then you write the number of packages you'll be given. That's the number of patients and the packages you're about to give. Question?
Do we have
One more question.
A phone call from Russell County?
Yes.
Hello.
Hello.
Yes, this is Russell County.
Hi.
And our question is, we have patients in Russell and in Lee who do not read Spanish nor English. And we would want to know what would we do in instances like that? You're saying this is
Okay. So the index patient cannot read, right?
Yes.
But
they may be Spanish and they can't read Spanish, but we have some English that can't even read. They're illiterate. How do we, in dispensing these to their
Okay. You can, if they are proper candidate, if they qualify, you can administer or provide PDPT.
Not the patient. I'm saying if we were to send medication with the index patient to their partners, what if these people can't read?
Okay, but you want to go over the counseling, during the counseling process, you're going over the whole process for the patient. Right? That's what we said from the beginning. Go over the process. But if you think they cannot follow your instructions, then they need to come back to the health department. If that's the only thing they will understand, let your sex partner come back to the clinic, then we need to just do that. Did I answer your question? Hello, Russell? Another phone call.
Yeah, we have another phone call from Baldwin County.
Yes.
Hello, can you hear me?
Yes, I can hear you.
This is Teresa from Baldwin County.
Hi, Teresa.
Hi. I've got a couple of questions on the PDPT packet for the sex partner. What exactly do you put on the label for that?
On the bottle or the whole package?
Yeah, on the bottle.
On the bottle. On the bottle, it will be our regular medication labeling instructions. So if you have their computer label that you can print and put on it, we already have in the protocol what information should be put on the label, and that's what we put on it. Otherwise, we need the patient, the medication name, that if it's chlamydia, we should have azithromycin, the dosage, and then instruction how to take it. We're going to have to the patient name, the partner name, not the patient, not the index patient, but the partner name on the bottle.
Okay. Okay, I got one other question.
Yes.
On the required information, sex partners required information, name, date of birth / age, medication allergy.
Yes.
What if they tell you they don't know their date of birth or if they have a medication allergy?
What if they say they don't know date of birth? That's fine. What about the age?
Or medication allergy. What if they tell you they don't know that they have a medication allergy or not?
If they don't know medication allergy and they said they don't know, we'll give it to them.
We will?
We will. Because we will further instructions to ask the partner themselves if they have allergy. And they're not supposed to take it if they have allergies.
Okay, so I just want to make sure I understand. If the index patient says they don't know if the sex partner has a medication allergy or not, we can still give them that PDPT packet, or that's okay?
That's okay. That's okay. And we make sure we emphasize, that's why I say we have to go through the form, the package, and explain everything to the patient themselves, because that's what they will be doing for the partner. And so we stress, since you don't know the allergy status, remember to stress that that's number one on the medication. If you have any problem, don't take it.
Okay. All right. Well, that was all the questions I had. Thank you.
You're welcome.
We have another call
Another caller?
Morgan County.
Hello, Morgan County.
Hey, Agnes. This
Yes.
is Terry from Morgan County.
Hey, how are you?
On the CHR 12C,
yes,
we asked the question, how many sex partners in the past 3 months?
Yes.
Or 90 days. And you keep referring to limit the package to like 5 partners in the past 60 days. So are we asking for partners in the past 3 months? Are we going to treat the ones in the 90 days, or is it just 60 days?
We are treating the ones in the past 60 days or the most recent. So if the 90 is the recent, we use that.
All right. Thank you so much.
You're welcome.
We have another one from Talladega County.
Talladega? Yes. Hello?
Hey.
We're listening.
Oh, okay.
What's your question?
On the index patient, if we do a web prep,
yes,
and we treat them that day because they had trichomonas,
yes,
do we wait for the lab to come back before we give the patients?
No, ma'am. If you do wet mount and you see trichomonas, that's a diagnosis.
Correct.
So we can use it that day if the patient qualifies.
And then we go ahead and give the patient
the package.
Okay.
For the
that
partner.
was my question.
Yes. Remember back in the days, all we have was wet mount. Yes. So we're still holding on it.
Okay. Thank you.
You're welcome. Any more questions? Okay. So we just go through our summary, and we say we are limiting to index patients with positive chlamydia or trichomonas. Think about the criteria. They must be qualified. Obtain sex partner name, date of birth, age, medication or allergy information. And then we need to go through counseling, the medication, the disease, precautions, and the fact that we are using it for symptomatic patient, index patient, but if the sex partner has symptoms, is symptomatic, they need to come to the health department or see a provider. We have a caller.
This one's from Tuscaloosa County.
Hello, Tuscaloosa County.
Yes, my question. And working in the family planning clinic,
yes,
since we don't use the DCS-12,
yes,
are you all going to come out with a stamper to make our life a little easier?
Just use your CHR's B or A you use, and just write it out for now until we come out with something with Family Health Services. Did I answer your question?
It does, but just I guess looking at how simple the CHR for the DCS was, that's why I was curious. But thank you.
Yeah, we hope we come out with something that make it simpler.
Okay, thanks.
You're welcome. All right. I think our time is up. And if you have more questions, please direct them to me. Thank you so much.
Make sure you complete and return your sign-in sheet and evaluation form for credit.